Good morning. So let's start with the dissection. Say today we'll be talking about all the great vessels and the nerves. Now what we'll be doing is we'll start again like every time from the point where we left last time, right? So from that perspective we'll start again creating we'll start dissecting layers one by one, and this is what we'll see today. Right? We'll see aorta, pulmonary trunk, superior vena cava, inferior vena cava, azygos veins, obviously hemiazygos, accessory azygos, right? That's what I'm not writing, but we'll see that. Then we'll see the phrenic nerve, we'll see the vagus nerve, right? And we'll see intercostal vein, artery, nerve, and the sympathetic chain, right? Sympathetic chain. So much. This is what we'll see. Not only that, we'll also be watching the branches, which are the main branches of aorta. So we'll be watching all those subclavian arteries, those common carotids, right? How they are formed. Everything is what we'll see. So big portion to cover. The most important part is you have to just watch that how things are in relation to each other, right? Because everything is carrying some clinical weightage. And as promised, tomorrow we'll be discussing radiology. And in radiology, we'll be discussing the X-ray chest in detail. Now, when we'll be watching X-ray chest, at that point, all these structures, they'll be coming into picture, right? That is when we'll see that, okay, this is how the aortic knuckle is formed. It is simply because that arch of aorta, today what we'll see that how it really goes from anterior to posterior, and that would be forming the aortic knuckle because it will be just creating the Silhouette, right? What is called as the Silhouette, or the edge or the margin, right? Shadow margin. All those things tomorrow. For today, let's start. So here is what we left last time, right? When we said that these are the two cavities, these are the pleural cavities, and these pleural cavities, they are covered with the pleura, and that is the parietal pleura, and then there is lung, which is covered by visceral pleura. Between visceral pleura and parietal pleura, there is fluid, and that fluid is which is creating that negative pressure, and it is keeping the lungs inflated, right? Lungs inflated. That was the reason when we understood that for the respiration we have to exert, we have to use energy for inhalation, but for exhalation or for the expiration, no energy is used. Just let the muscles go, and the elastic recoil of the muscle of the lung, that will automatically collapse, right? And then the air would come out. So this portion in between, that is the mediastinum. Just a very quick thing, what mediastinum is. Mediastinum is a space which is practically between two lungs, right? So the whole thoracic wall is you can say something like this. This one is mediastinum. This is right lung, this is left lung, and in between over here, even there would be our favorite heart, correct? And obviously all the blood vessels and the trachea, esophagus, all those things is what we'll see today. So here is, as we rotate, right? So what we did is we are just rotating. So we are watching the left side, that you can make out very easily because this one is our heart. Why I'm writing heart like this, right? This is much better. Hai. So this is heart. From heart, the thing which is coming out, and this very classical shape, and this one is aorta. Aorta divided into three parts. It goes like this when we see it in 2D, correct? So this portion will we call as the ascending aorta. This one will be the arch of aorta, and this one is the posterior or the descending aorta. But what we really want to see is if this is something which we are watching from the left side, so here is the descending aorta which is posteriorly situated, right? This one is posteriorly situated. That's the point. That's the point which we have to watch, right? This is near to vertebral column, right, near to the vertebral bodies. So when we'll be taking tomorrow, when we'll see, we'll even see some of the sections and we'll see the CT scan. So when we take a slice, right, and when we'll be able to figure out vertebral bodies very easily, immediately, something which will be very round, absolutely round, perfectly round, because this aorta, it is quite a thick wall structure, perfectly round, right, as compared to when it will come to the vena cavas, right? So this is the structure which will be near the vertebral bodies, and will be able to make out that yes, this is aorta. Then depending upon the level, we'll find out that which part of it is, right? So that's what we remember, that it is posteriorly situated. It means it is taking absolutely a 180-degree turn from anterior. It is going towards the posterior side, right? But such things are to be remembered. So this curve, if we write in slightly more detail, so if we say this is descending, so then we can surely say this is, or let's write it over it, this is arch, arch of aorta. And during this description, right, during this description, we said that this is the angle of Louis, right, which we feel over here, the junction between manubrium and the sternum, that ridge which you can feel. So it is this level where it is this ascending aorta ends, right, arch of aorta starts and ends, and descending aorta starts, correct? That's the level. So this is angle of Louis, and I hope you remember that what other things were also happening, right? That is what we'll see even today, right? The way trachea and it bifurcates, right? And today we'll be watching many of those structures. Okay, it goes down, and then it goes all the way into the abdomen. That means this one is diaphragm, right? Huh. As I received few emails, so today I have done that, right? Instead of putting all the figures separately, I'll be leaving few of the figures unmarked. So I'll just write that this is for practice. That is what we used to do even in the when we used to discuss upper limb, abdomen, etc. So some of the images would be doubled. So simply when those images will come, I'll say use this thing as practice, right? So you can label it. Okay. So that's the point which we learned. Arch of aorta situated posteriorly is the descending aorta, and it goes pierces the diaphragm and it goes below, right? Now in order to see the structure still more clearly, once again we have rotated our this gentleman onto the anterior side, and now we'll remove one pleura, right? Remember, we'll be removing pleura, because when we remove the pleura, what we see inside is the inside of the mediastinum, correct? Inside of the mediastinum, because mediastinum is that pleura which is covering, and the space inside is the mediastinum, right? So that pleura we remove. We'll also remove the pericardium, right? Pericardium, though we have not discussed yet pericardium, but just take it like that it is the covering on the heart. Why we want to remove it? So that we can actually watch those vessels crisp clear, right? Because pericardium also covers root of those great vessels, right? So when we say that this is the left ventricle, from left ventricle goes the aorta, but that pericardium, it covers some of the portion. So because we want to see these great vessels very properly, we are removing the pericardium also, right? Okay, so pericardium removed. Then obviously the sternum which is in front of us, we want to remove it so that things are crisp clear. So sternum will remove. Plus the manubrium, right? The upper portion will remove even half of the manubrium, right? So manubrium is also getting sacrificed now. So everything becomes clear. So here is done, right? All those things done, what we talked about. and we would love to watch it from the sideways, so let's rotate, right? Acha. uh, as you said in your emails, I am writing this, that please write when we rotate on left side or right side. See those, I don't mind writing it, but say now I feel like you are mature enough and you are sharp and intelligent enough to understand that whether we are rotating on right side or left side. But still, I don't mind writing it, right? But in case of any query, do ask. And as far as possible, say try to remember that what structure it is, because in every section I won't be writing each and every section, but yes, I might ask, right, that what is this or what is that. So that way try to orient very properly. Otherwise, over here we are rotating on the left side, right? We are rotating on the left side because on left side only the heart and major vessels are there, right? So when it will come to say vena cava, right, vena cava, superior vena cava will be going on the right side, because here is superior vena cava. So at that point we have to watch it from that angle, right? We have to watch it from that angle, from the right side. So at that point we'll rotate from the right side. We are going in the order that first artery. No, there was no lecture, right, Rahul? We are meeting on Monday, Wednesday, Friday, and Saturday, right? So today we are meeting. On Saturday, tomorrow we'll be discussing X-ray chest. Then we'll be meeting on Monday, and we'll start watching the organs, right? So next week, just take it like that. It is almost the entire week is for cardiology, right? That is where first we'll understand the anatomy of cardiology, anatomy of the heart. Then we'll also learn the physiology, in which we'll spend 2 days on the physiology and even the ECG, right? And then my wish is to show you even the angiography and the CT scan and MRI. Well, let that time come, right? Today, moving on to this rotate, we rotate on the left side, right? And we rotate on the left side, easy, right? Now see things which are seen very clearly because we have removed the pericardium. So here is, this is our ascending aorta, right? Ascending aorta. Ascending aorta comes out of left ventricle, right? Ascending aorta has got no branches, right? It has got no branches. This one is arch of aorta, so that is also good. Yes. The reason is that today only you will see that there is so much of stuff, right? So at times it takes some time to prepare this, and plus that is from the my side. And from your side, I wish that when we move on to the next session, right, every portion of whatsoever is discussed over here, you should be knowing it, so that we keep on mounting more and more stuff in our subsequent lectures, right? Otherwise, say there were few emails about that we are unable to cope up. Well, we can't slow down more than this, right? So in a week at least we'll be keeping 4 sessions, but the gap is put deliberately so that you revise the things properly. And it has to be like that when we are discussing, say for example, fifth session, so 1 2 3 4, all those things, they should be known to you. Today only you will feel that, right? Many of the things which we have already discussed, you will be watching it practically. Okay, so arch of aorta, that is arch of aorta, and this one is the descending aorta. So now onwards we'll write it like this, right? Descending aorta, and ascending aorta we'll write it like this. Acha. Now this portion, this is pulmonary trunk. This is pulmonary trunk, right? Pulmonary trunk which comes out of left ventricle, right ventricle, right? Right ventricle. When it goes out of right ventricle, that means it will be going, right ventricle, which will be going, and it will be dividing into right and left pulmonary arteries, which will be going into the lungs, right? So that one is our pulmonary trunk. Now as it goes up, right, as it goes up, right? So this runs upwards, right? So this is, now we zoom to this. We want to see some of those structures. Thank you. Acha. Can you see this structure, right? A very, very delicate structure. What I'm talking about is this. What I'm talking about is this structure. This. Zooming it, right? This structure. What structure could it be? Right? Something a thin structure, right? Which might not, which is not functional. What structure could it be? Giving you a hint that it is connecting two tubes, right? It is connecting two tubes. This is what? This is pulmonary trunk, okay? And this is the arch of aorta, right? This one is arch of aorta, right? Arch of aorta. So arch of aorta and pulmonary trunk, right? They are getting connected by this something which is non-functional. What could it be? Could it be? Very thin, right? Who knows? In past, it could be a bit thicker. It could be functional. That's right, right? This is ligamentum arteriosum, right? This is the memory of ductus arteriosus, right? And in fetal circulation, you know that ductus arteriosus, it is like a connecting tube. It is like a connecting tube between pulmonary trunk and arch of aorta, because we don't want to waste any blood. So that's why whatever the blood which was even the small amount which was present into pulmonary trunk, because most of the blood it must have passed through foramen ovale, right, from right atrium to left atrium, gone, right? But still some blood over enthusiastically enters into the right ventricle. So from right ventricle it would come into pulmonary trunk. That blood would be wasted because in any case it is not going to the lungs. So that's why it goes via this and it reaches to the arch of aorta. And this one, so very rightly said, this is ligamentum arteriosum, correct? Ligamentum arteriosum, which is a remnant of ductus arteriosus. Perfect. Other structure which are just near to it, right? So this pulmonary trunk, it's something like this. It divides like this, right? And as we watch it over here, so this entire caliber, this one, that is, we are on the left side, right? So this is left pulmonary artery. From heart to lungs, pulmonary artery. Just underneath this one is the main bronchus, right? Left main bronchus. Because that's the point where the trachea would come and trachea would divide. So this is left main bronchus. So if left bronchus is there, where is trachea? Well, the trachea is hidden. This one is trachea. Right. I'll change the color. Right. I'll change the color. This one. Yeah. Right. So that is trachea. We'll be able to watch trachea from many angles, right? But that's the location of trachea. So now it is giving the hint that trachea is going and then it is dividing, right? Please avoid these questions from which university and that university. And then there are small veins, right? This is big main bronchus, and then there are several veins over here, right? These are nothing but left pulmonary veins. There will be many, right? So these are the left pulmonary veins. So we have got left pulmonary veins, we have got the main bronchus, right? Left pulmonary artery, which is divided, which is from pulmonary trunk, and this big one is the arch of aorta. So all of them, they are surrounding this structure, right? This is where the root would be formed. Root of left lung would be formed. That is left main bronchus in the left pulmonary artery, left pulmonary vein. Okay, take this figure as for the practice, right? This is for the practice. So in order to see the branch of aorta, right, now we are focusing, first we'll finish the aorta. So over here, now our purpose is to see branches of aorta. Now aorta has got something like this, right, branches of arch of aorta. So it would go like this, like this, like this, right? So this would be, the first one would be the brachiocephalic artery, or it is also called as the innominate. Okay, I'll write it here, right? Also called as the innominate artery. And on left side, this is left common carotid artery and left subclavian artery, right? So here is the manubrium, right? This one is the manubrium. And just underneath this first one, so I'm just writing 1, then this one is 2, and this one is 3. But well, things are not that crisp clear, right? Because if we say this one, that is the, say, brachiocephalic, this is left common carotid artery, and this is left subclavian artery. So let's remove the structure which are overlapping, right? So this is where, this is the root, right? We can at least say this one is bigger, right? So this would be the place for brachiocephalic, right? By the way, this is superior vena cava, right? Which we'll be watching shortly. But because we want to see it, let's remove superior vena cava right now, right? Superior vena cava, and it is formed by these brachiocephalic veins, right? These are brachiocephalic veins. So even that also we remove, right? Okay. Now we can see things in much better shape. So this is where the first, this is second, this one is third, right? So first one is brachiocephalic artery, right? Brachiocephalic artery, that is 1. Second one is left common carotid artery, and third one is left subclavian artery. Better, right? Now we can see, we can have a look at it in a much better perspective. Okay, to see still better, that's the manubrium. Remove it. And this one would be the first rib. First rib. Let's remove that also. So area becomes clean. Here it is. Now we can watch things much better, right? All these as if like it is a book picture, correct? So this one is brachiocephalic artery, right? This one left common carotid artery, and last one over here, it is left subclavian artery, right? Very clear. Yes, it is when you take a pulse, right? You are taking the pulse of this common carotid, because it is emerging directly from the heart, right? Directly from the aorta, and that's why it is a very high pressure system, right? So that's why you can feel the thrust right? You can feel the thrust very strongly. Now this subclavian will be going where? This subclavian will be continuing as an axillary artery, and it will be supplying all the way to the upper limb, right? To the upper limb. Common carotid artery, right? As will it proceeds up, it is divided into internal carotid and the external carotid artery. Internal carotid artery and external carotid artery, and that is what will be supplying the brain and head and neck. Head neck, right? That is what is supplying. When it comes to the right side, this brachiocephalic artery, right? It divides into two, right? This brachiocephalic. So this is one, and that one is right common carotid artery, and then this one, right? This one. It is the right subclavian artery. Right subclavian artery. So far, so good. Watching it in more detail. There is a muscle which we must know. And this muscle, we are talking about this muscle, right? We are talking about this muscle. This is the anterior scalene or the anterior scalenus muscle. So this subclavian artery, right? Subclavian artery, this one and this one, right? This subclavian artery goes underneath this anterior scalene muscle, right? Do remember this, because this would be one of the very important differentiating point. Just telling you that there would be subclavian vein also, right? If there is subclavian artery, there will be subclavian vein also. Subclavian vein will be passing in front of the anterior scalene muscle, and subclavian artery is behind the anterior scalene muscle. So here we are watching that it is behind, right? This is also anterior scalenus or anterior scalene muscle, and you can watch that this particular one, right, this artery, right, this one, and it is passing behind, right? It is passing behind. That one is left subclavian artery. Good one. At this point of time, as such, there are so many branches, right? But because this subclavian is the part of, right, that would be, say, some of its part is part of upper limb. But one important artery which we must know, or one important branch, can you see this one branch which is coming out, right? This branch, this is very vital branch. It is called as the internal thoracic artery. Internal thoracic artery. Now this internal thoracic artery is very typical. Its dissection is also very typical. So to see this thing with still better clarity, what we do now is we put back the manubrium and first rib, right? So we'll put manubrium, we put it back, and rib number 1, right? Rib number 1, we put it back. So to see its exact relation, that how it is really forming. Yeah, so we put it back. So here we now see very clearly that two things which we have to watch. Internal thoracic artery, it is passing just behind this rib 1, right? So this is, name is internal thoracic artery. It will be going inside the thorax, right? And it is behind rib 1, right? That is first. And second, we already saw that this subclavian artery, right? This subclavian artery is under anterior scalene, right? Anterior scalene muscle. That's our anterior scalene muscle. So this one would be our subclavian artery, right? And see, here it is. This is subclavian, the boundary. This one is the cut end, right? That's the subclavian. Now I think you should be able to appreciate it better, right? And this big one, right? This one is the muscle. This one is the muscle, right? So that's the subclavian, and internal thoracic is the branch of it. So that's the internal thoracic. Now, if we rotate, right, we are watching something super interesting, and that is that this subclavian artery, right? This subclavian artery, this is easy, right? This one, right? That is internal thoracic. But as we said that this subclavian artery, it will be doing something for the brain, and that's our vertebral artery. That's our vertebral artery, right? Vertebral artery, and very next to it over here, right? You can see that these are the two branches which are going from the subclavian. So that is thyrocervical artery, right? Thyrocervical artery. Now, this vertebral artery, that is of tremendous importance. The reason is that vertebral artery is that artery which is forming what's called as the one of the important part of the circle of Willis, right? Uh, let's do one thing. See, though we are deviating slightly, but we'll make the picture crisp clean, right? You will really enjoy it. What we are understanding now is that, okay, we understood that these are the vessels. So take it from here, that vertebral artery you saw, right vertebral artery. So vertebral artery. This is posterior portion, back, right? So they will be going into the vertebra. That's why it is called as vertebral artery. Both the side, right side and the left side, left vertebral artery, they unite. They unite at the base, and that's why this is called as the basilar artery, right? It is called as the basilar artery. What we are discussing, or will make within just 2 minutes, will make the entire circulation of the brain, right? So that is the basilar artery. And then this basilar artery, it divides. Now over here, right, there is cerebrum. So that's why when it is dividing, so we'll call this as posterior cerebral artery, right? So here also it is posterior cerebral artery. This much work is done by vertebral artery, and that's why we studied that vertebral artery. Now we know the importance of this artery, right? देखने में it is so small, but it is so important. So they will be going back. Now we know that from here, though we are watching in 2D, but from here they'll be going back, right, into the vertebra, and then through that vertebral foramen they'll travel up, and then they both will meet to form basilar, will enter into the skull, and then it is at the base it is forming this basilar artery, right? So this is at the base. So from here, right now I'm not adding all those pontine arteries and those other inferior cerebellar, etc., right? They are all there, right? Because from here it will be supplying to pons, so pontine arteries, etc. But don't worry, right? That is when we'll be discussing the brain. So far this is easy. Now comes our carotid, right? Out of which internal carotid, right? So that internal carotid, it enters into the skull. There is this carotid foramen, right? So there is a carotid canal. In fact, it is like a canal. So via bone it enters, and it enters into the skull. So take it, I change the color, right? So via bone, right, big caliber, right, it enters into the skull, right? It enters into the skull. So this is our internal carotid, right? Internal carotid artery. Now when that internal carotid artery enters into the skull, it divides, right? And it gives a big branch like this, like this. Now we have already said that this is posterior cerebral, so we'll be calling this as middle cerebral, right? This is middle cerebral artery, right? This is middle cerebral artery, so it divides. Also it gives one more branch, right? And that branch will go, right, from here it will go and it will talk to this posterior cerebral artery, because they want to form the whole circle. So a branch goes. Now it communicates, it talks middle and posterior talking. So that's why this artery will be named as posterior communicating artery. It means there would be someone on the anterior side also. Yes, it would come. So this is posterior communicating artery, right? Same way, this is posterior communicating artery, right? And then there would be one more. That will be, let's see the color once again. That would be over here and over here. Again, cerebrum is here, so we say this as anterior cerebral artery, right? So easy, anterior cerebral artery, anterior cerebral artery. Okay, so it goes like this, right? And then both these arteries, they talk with each other. This one, they talk with each other, and very lovingly we give that the name as anterior communicating, because it is the anterior most, right? Let me write here, right? This is the anterior most, so that's why this one is called as the anterior communicating artery. Done. This is what is called as the circle of Willis, right? This is called as the circle of Willis. This is just to show that what is the importance of this internal carotid artery, what is the importance of vertebral artery. So internal carotid, this carotid, right, it goes from common carotid, then external carotid for the face and everything. Internal carotid goes inside the skull, right, inside the base of the skull, through carotid canal, enters into the cranial cavity, right, that is near the brain, and this vertebral takes the posterior part, and that's how they form this circle, and that is the circle of Willis, right? He was the Thomas Willis, under the name this is given. So this is like blood supply of the brain, though there are some small other vessels also, but for now, for this point, this is more than enough, right? So that we know the importance. Okay. So coming back to our say thorax part. You know this, right? You know this, all those three vessels, right? See how beautifully it is seen. See this, right? This one, right? So this is what? This is the right subclavian, right? Right subclavian artery, and it will be continuing as an axillary artery, right? And then it will be supplying all the way to the upper limb, right? This muscle, see this muscle, this is the anterior scalene muscle, correct? Anterior scalene muscle. And now you know the rest one, right? This is the common carotid, that is the right common carotid artery, and we have got the left common carotid artery and the subclavian. This is the left common carotid artery, and the subclavian, that is on the opposite side, right? So we can't see it from here. Okay. So once again, this is the anterior approach, and here in this, rest of the structures are fine, but this is seen very nicely. This is our internal thoracic artery. The dissection which we are now about to do is that it is internal thoracic artery which runs, this is like that first costal cartilage, right? If we say this is the rib 1, right? This is the rib 1. So this one would be the first costal cartilage. First costal cartilage. So it runs behind the first costal cartilage, right? And then it goes back. But where exactly it goes? For this, this is a very different type of dissection which we are now about to do. What we are doing is, we'll just take the anterior chest wall and we'll flip it as if we are seeing it from inside, right? We are seeing it from inside. Let me explain it properly, right? Say this is the structure, right? And we see this. This is, once again, you can use it for practice, right? It is the same image. I put it twice. You can use it for practice. This one. Say this is what? This is anterior chest wall, right? So anterior chest wall. But what you have to really understand is that is we are watching from inside, right? So seen from inside. Now normally we don't see it so clearly, because for this what you have to do is you have to just cut the anterior chest wall and then flip it and then you watch it, right? So this is the front and this is the back. So we are watching the back or the inside of the anterior chest wall, and this is the beauty. That internal thoracic, it is here. It is here. That is the internal thoracic artery. This one and this one. Oh, let me draw it like this. This one, right? And this one. Yeah, now it is fine. So it goes, right? What it will do, it supplies obviously anterior chest wall, right? So it's very simple. It supplies anterior chest wall. So that is the internal thoracic. Now it goes down, right? As we'll see that, see, it goes down, right? It goes here. So there are few muscles which are overlapping it, right? This is transversus thoracis. So these muscles, so because we are watching from the back and the muscles are overlapping, it means this artery is running in front of the thoracis, transversus thoracis, right? Transversus thoracic muscle. So it is running in front of transversus thoracic because we are watching from the back, and it is from the, and this one in between is the sternum, correct? This one is the sternum. So it is going parallel to the sternum in front of transversus thoracis, and then that's how it goes all the way down, right? All the way down. So if we really trace it, and now this is the, so this would be the location of xiphoid process or the xiphisternum, right? This one would be the xiphoid, right? This is like our costal margin, right? Costal margin. Fine. So that artery, and see the muscles, transversus thoracis, here are, right? See how nicely this one, right? All those transversus thoracis, they are there. And this artery, right? It is giving its glimpse here, thoda here, and then it is coming out, right? So let me remove this so that you get a better picture, right? So that's the artery it goes. Yeah, he's seeing like some plastic is covered. Actually, it is like that, right? Because that is as if it is some plastic is covered. Good. And as this artery comes over here, now do you remember that this was the level where the diaphragm was attached? You know? Diaphragm was attached. So this particular artery, right, it continues, right? it continues as superior epigastric artery and it supplies the anterior abdominal wall, because see this portion, the diaphragm is attached and it goes anteriorly and all the way it goes to supply the upper part of the anterior abdominal wall, right? So this is the internal thoracic artery, thoracic artery, and it will continue as, remember the name, right? It is superior epigastric artery, right? This is the direct continuation, right? It is the continuation as, and that is what will be supplying anterior abdominal wall, right? Upper part. Right, so far all good. So do remember one thing, that this superior epigastric artery, right, which is as such supplying anterior abdominal wall, is as such coming from very early stage from the arch of aorta, right? From very early stage of the arch of aorta. That means if there is coarctation of aorta, that is when the aorta is constricted, so then there would be back pressure over here also. But this much you remember, right? This is what I mean to say, that if this is the aorta and over here and from here this is coming up, right? Similarly from here this would be the internal thoracic, and that is, it is continuing as superior epigastric artery onto the anterior abdominal wall, right? So if there is any narrowing, so there would be increased pressure over here, so that back pressure would be transmitted over here. So these delicate vessels, which are quite thin, right, they will be now enlarged, right? So just keep this thing in mind when we'll be discussing clinics. At that point all these things will come into picture, right? How the back pressure gets transmitted, how so many symptoms they really develop due to this. But that's where we learn the anatomy. Achha. Now for descending aorta, now we talk about descending aorta. For descending aorta, to see it properly, we remove the ascending aorta and arch, right? So we remove that, and chalo, we remove the heart also, right? Very painfully we remove the heart temporarily. Here it is, right? That's the descending aorta, right? Descending aorta. We need to see the structure. This is one interesting tube which is passing, right? This tube is esophagus, right? This is esophagus. How can we identify this esophagus? Because esophagus, right, this is a tube which is normally a collapsed tube. So when you'll be watching the sections, right, you'll find that a section which is something like this, right, this would be the esophagus. Trachea, that would be seen wonderful, right, because we'll be able to see even the cartilaginous rings. So they will be seen very clearly, right? Aorta, very nice rounded structure, right? Vena cavas, right, though thin walled, but it is quite big. But esophagus, it can be seen as a collapsed one, right, because of the nature. So as we'll see it in CT, it would be easy to identify. But important is, esophagus is near the descending aorta, right? How do we say the relations, right? Well, over here this is medial, right? It is medial to aorta, correct? We are talking about esophagus. So this is medial to aorta. As it goes down, it becomes front, right? So over here, near the diaphragm, we'll find that this is in front of aorta, descending aorta, right? It means if I take a section over here and if I take a section over here, right? In CT scan, so there is cut, right? All those sections. So in the higher sections, you'll find that esophagus and the descending aorta, they both are at the same level. But then they will be changing their position as you are approaching towards the diaphragm, and esophagus will come in front of aorta, right? Very small thing, but when you'll be watching CT scan, right, there would be a aha factor. Yes, crystal clear, right? Because this is how they are. And this gives you that understanding that sometimes when the structures, right, when the structures they rotate, so and then when you are taking those sections, so that is how you will find that this is how they are changing their orientation, right? This is where you need to visualize. The moment you can visualize this, right, instantly things will become so interesting. So I hope I'm clear in this, that when you take a section at this level and when you take a section at this level, what would be the relative structures, or what would be the relative positions of esophagus and aorta as compared to situation number 1, or the slice number 1 and the slice number 2, which is near the diaphragm. Near the diaphragm, right, esophagus will be in front, right? It is coming in front of aorta. We are watching this patient, this gentleman from front, right? From front. To see the structure still better, to see, because our prime aim is aorta. So over here, let's sacrifice the esophagus, right? Let's sacrifice the esophagus, because then we see that what this descending aorta will do. Here it is. This is the descending aorta, right? This one is descending aorta, and this descending aorta is giving some very good branches, right? We can see it so cleanly, right? All these branches, right? This one, right? All of them, right? All of them. They are posterior intercostal arteries, right? They are posterior intercostal arteries, 3 to 12, right? These are the branches of descending aorta. Now these intercostal arteries, they will be accompanied by intercostal veins, intercostal nerves, and yes, we'll be watching all of them, but right now we focus on intercostal artery. Remember, the situation would be vein, artery, nerve, right? So we are talking about right now intercostal arteries, right? So that means all these three things, they will be into the groove. We have already seen when we were discussing that rib, right? So in rib there is a groove. So in that groove, in the lower border of the rib, in that groove, vein, artery, nerve, in this order they sit, right? So this artery is between intercostal vein and the intercostal nerve. We'll see how intercostal vein is formed. We'll see how this intercostal nerve is formed, and we just saw how the intercostal artery is there, right? So we are clear about intercostal arteries. See here, right? Still more clear, right? And that's how they are. See all these arteries, right? Very clear. So let's keep this image clean so you can have a look at it. Yes, obviously intercostal veins and intercostal nerves, they have been removed. This is what I was talking about, that, right? It is this groove. It is in this groove where we have got vein, artery, and now that intercostal, right? In this groove on the lower surface, lower edge. So this is a groove. Now let's talk about the veins, big veins, starting with superior vena cava. Because inferior vena cava, it has got very little role in thorax, right? It will just pierce the diaphragm and immediately it will go into the right atrium, right? But superior vena cava, very interesting. Now see, superior vena cava, this is like vein. So vein has got tributaries. That means they will form like a river, right? All those veins, they will join each other and will become bigger and bigger and bigger. arteries, it has got branches, so they divide, become smaller, smaller, smaller. So over here, when we say superior vena cava, so there from the, again there would be subclavian vein, right? From top there would be the internal jugular vein. Yes, azygos vein will come, right? So this subclavian vein, internal jugular vein, right? And it will lead to form what is called as the brachiocephalic vein, right? So this is brachiocephalic vein. This is on right side. Similarly, there would be internal jugular vein, there would be subclavian vein, this is internal jugular vein, this was right side, while this one would be on the left side, and that will also lead to formation of brachiocephalic vein, the left side. Both of them, they would join and it will lead to formation of our superior vena cava, right? This subclavian is coming all the way from the upper limb. This internal jugular is coming from the top, from the brain, right? And it leads to superior vena cava and it goes into the right atrium, right? In this inferior vena cava will come from below, right? And it will join once again into the right atrium. Let's see this. To see this structure, we need to remove few muscles, right? One of the biggest muscle, which is covering almost entire thing, is the pect major, pectoralis major. So we would like to remove this muscle, and this muscle, right? This one, that is sternocleidomastoid, right? Because it is covering almost this entire area, right? It's a big area, and that's where we want to see. So we clear this sternocleidomastoid, right? Which is connecting sternum, cleido is clavicle, and mastoid process, that is just behind the ear, right? So we remove this muscle also. So these are the muscles which we remove, and we see something, right? This one is internal jugular vein, right? That one is internal jugular vein, and here it is, right? That is the subclavian vein, right? Obviously the right one, right? This one is the right one, right internal jugular. There is a small muscle, right? It's like, if you can remember, if you can watch it, right? This is a muscle. See, I put the line on this. So now you'll be watching it, right? This one. This muscle is called as the omohyoid. Very important, right? Do remember. Omohyoid muscle. So that is omohyoid. This small, we have removed the pectoralis major. Say internal jugular on both the sides, right? On both the sides. We'll be watching it on the opposite side also, right? So that's why this is right internal jugular. There would be, say this is internal jugular, there would be external jugular vein also, but external jugular is smaller one. Again, it would be landing over here only. I'll show you. So just underneath the pectoralis major, there is a small muscle which you can watch over here. This is pect minor, right? Younger brother of pectoralis major, right? So that is pect minor. So underneath that, this subclavian vein is passing. Yeah, this is bit of zoomed view, right? So let's take it as a practice, right? Let's put it in the practice section, right? Because this is like internal jugular vein, this is omohyoid, right? This is subclavian vein. So you know this. So let's remove this, right, on both the sides. Achha. When we see this, right, as it goes down, one classical thing which you must have noticed, that all these structures, they are passing underneath the clavicle, right? This one is clavicle, the beauty bone, right? Clavicle. Let's remove the clavicle so that we can have a good idea, right? Correct. This reminds me of that, see, this is nothing but as a thoracic inlet, right? Right? This is where it, right, structures are there. So any compression can lead to a problematic thing, and that is if this is compressed, so then blood is coming from upper limb, right, and via these veins it is going. So if there is any compression over here, there would be swelling into the upper limb, there would be pain, there can be cyanosis, bluish, right? So that's what can happen. Well, that is the clinical part. Okay, so removed, right? We have removed the clavicle and immediately we see so many things, right? We see so many things. One wonderful thing which we are watching is this is subclavian artery, this one, and this one is subclavian vein, this one, right? And this muscle is the anterior scalene muscle, right? Nutrient artery for clavicle, yes, yes. They are. Okay. So anterior scalene muscle, right? Subclavian artery. Now see the subclavian artery, it is behind anterior scalene, and superior this subclavian vein, right? It is in front of anterior scalene. Important point. This angle, right? This is where this is subclavian artery, and this one is the internal jugular, right? This one is internal jugular. So this angle, it is also called as the venous angle. It is also called as the venous angle, right? Achha. From the perspective of, say, same thing would happen on the opposite side. This is internal jugular vein, right? And this one is the subclavian vein, and similarly this would be the angle. This would be the venous angle. ठीक? Now see, this venous angle is important because on left side, right, this is, remember, on the left side, thoracic duct would open into this. Thoracic duct, right, it opens. Now this thoracic duct, it's very, very vital. It carries lymph, and at the same time it would be carrying that chyle, right? It carries lymph which is from the lymphatic system, and chyle or the chylomicron which is by the intestines, right? So that thing is put, and plus there are other products also, right? Something which is for the fat and the lipids. So all these things which are from intestine, right, which is from intestine, it is put into the blood via the thoracic duct. So that thoracic duct, which will be carrying lymph and chyle, it will put all those contents into the blood at this junction, right? From here it will be carried to the liver by the portal vein, right? And it is the liver which will be metabolizing, right? So from here, thoracic duct, it will come into blood, and from blood, right, from blood by the portal vein, right, via portal vein, it will go into the liver, and further metabolism starts over there. So that's why this point is, this junction, this venous angle is very important. What about the right side? Say on the right side, on the right side, those lymphatic ducts will open, right? So there are lymphatic ducts, but thoracic duct is an important big structure. That's the reason that as things will proceed, we'll actually be watching even the thoracic duct in more detail. But just keep in mind, it is the venous angle, the junction or the point where internal jugular vein meets subclavian vein, that's the venous angle, and that's where thoracic duct would open. That's where those lymphatic channels or the lymphatic ducts, they would open on the right side. On the right side, left side is more important. Okay? Well, this you can take it for practice. Just this structure, right? That is our right common carotid artery, right? Because this is our brachiocephalic artery, correct? And then as it goes, this one, right? So that one would be the right subclavian artery. Right? Otherwise, this, do you know, right subclavian vein, and this is internal jugular vein, right side. Similarly on the left side, right, internal jugular vein and left side subclavian vein, and it forms. Can take it for practice. I think it is repeat, right? I put it again. So this you take it for practice. Take it this way, that in order to see this entire superior vena cava, right? We remove the entire anterior chest wall, right? So we want to see superior vena cava, right? And for that anterior chest wall, right, we remove fully, right? So when we remove this entire chest wall, clear? See, this is how it is formed. So you can see that here it is our superior vena cava, right? Superior vena cava, formed by the joint operation of this one is right brachiocephalic vein. This one is left brachiocephalic vein, and that's how they are formed. This is subclavian vein, right side. This one is right internal jugular vein, and similarly on the opposite side, right? On the opposite side. Fine. Point to be noted is that right brachiocephalic vein is shorter than left one, left brachiocephalic vein, because their combination superior vena cava is on the right side of the heart, right? But we are not more interested in this length. But one important thing is that if you really see the internal jugular vein, right, and then all the way it becomes brachiocephalic vein and all the way superior vena cava, and it enters into the right atrium, correct? The path is almost straight. So this means if we measure any pressure over here, it would actually reflect the pressure of right atrium, right? Because it is almost straight. So any pressure which is generated without any, because if it is on side walls, there would be change in the pressure. But over here, our internal jugular vein, right side, is almost same, almost continuous, right? It's almost as if straight tube which is landing, right? Over here, right, that subclavian would be joining subclavian vein, right? Subclavian vein is joining, then it is forming what? It is forming the superior vena cava. In superior vena cava, right, there would be, say, this brachiocephalic of the opposite side will be joining, but this column, that column always remains straight, right? Keep this thing in mind when we'll be discussing jugular venous pressure, right? It would be of importance. So as such, from the anatomical perspective, right brachiocephalic vein is shorter than the left brachiocephalic vein, right? Now we want to see this superior vena cava properly, so now we'll be rotating it, right? We rotate, right? So we are rotating it so that we see the right side properly. take it as practice, right? This is almost the same, right? Just the zoomed version. So this one would be superior vena cava, you know that, right? And obviously this is the ascending aorta, this one, right? This one would be ascending aorta, you know that. Ha. So we have now rotated it, right? We have rotated it. So looking behind, we have rotated it so much, right? So we are watching the posterior part. See, these are the all the vertebrae, right? Vertebral bodies, right? All of them. So we are watching it from behind. See, first thing, this one, that is trachea. That is trachea, right? And this one is long awaited azygos vein. Azygos. Now, you know, I never used to like this azygos vein क्योंकि समझ ही नहीं आता था कि what exactly is she doing, right? Anyway, so we'll understand it properly. So this is superior vena cava, and that's the point where it enters pericardium, right? Enters pericardium. It means when we'll be discussing pericardium, so we'll say this characteristic that pericardium, it also covers the root of those great vessels, right? It covers the root of those great vessels. So that is superior vena cava. Now, if we really want to watch inferior vena cava, we have to see, we are pushing the heart. We are pushing the heart. We are lifting the heart. This one is diaphragm, right? This one is diaphragm. And we are just pushing the heart above to just watch this small portion. And that is, friends, nothing but our inferior vena cava. Right? That is the inferior vena cava. Inferior vena cava, as such, if you see, so we have in lower limb, there is external iliac and the internal iliac vein, right? So that's how they are formed. So external iliac vein and the internal iliac vein. That leads to formation of common iliac, right? Common iliac vein. So obviously this side is the right side. Similarly, on the opposite side also, there would be left common iliac vein, right? It is over here. Combination of both of them, that leads to formation of inferior vena cava. Obviously over here, right, it will be joined by, say, renal veins, right, from the kidneys. Then there would be, from here, there would be suprarenal, right, suprarenal veins. But then this IVC, it continues up. It pierces diaphragm and immediately it enters into the right atrium. So that's the reason we are watching only a small portion of inferior vena cava, which is just underneath the heart and then straight away. So that's why the major portion of IVC you will watch in abdomen, right? Very, very rich topic, but obviously major portion would be into the abdomen. So over here, we'll touch IVC only up to this point, right? And this is just for our understanding that how it is formed, right? Inferior vena cava, inferior internal iliac vein and the external iliac vein. Achha. Now for this, say azygos is what we are watching, right? And the most mysterious one, right? Now see, this azygos is looping over something which is such a big structure, right? And that was the trachea. This one is the trachea, and it is this trachea which is now dividing. So that's the right main bronchus. That's the right main bronchus, right? So it means this azygos is taking turn, right? And it is going posterior. It is going back, right? We can appreciate that it is going back. And even to watch this, we had to rotate it, right? We had to rotate it. So what this azygos is actually doing, to see this thing, we have to once again become bit heartless, right? So we have to remove the heart plus we would like to remove all the structures which are in front. So mediastinal, we write mediastinal structures, right? Mediastinal structures which are overlapping it, we remove it. So then we just watch the azygos. And when I first time I saw the picture, there was an aha factor. Oh, acha, this is what really is happening, because this is what is happening on the, we are now watching the chest, the posterior chest wall, right? These are the vertebrae. On the vertebra, right? This is the azygos structure, right? This is the azygos structure. So orient yourself that from here it will be going into superior vena cava, but because we wanted to see it, everyone was overlapping it, so we said all of them, okay, right now all of you go away, right? Just watch the azygos. So this is the azygos vein, and what azygos is doing, it looks like fossil. Fossil of lizard or pata nahi, some dinosaur. So azygos vein, right? This is the azygos vein. And in one word, if we say that what azygos will do, azygos will supply posterior and lateral part of chest wall. So simple, right? It means that those vessels which are right on the vertebra, and then they will be going like this. So they'll be supplying the posterior part and the lateral part. Bus done, right? So it supplies posterior and lateral chest wall. Now things are easy, right? But this is on the right side and this is on the left side. Now normally right and left, they are almost similar, right? Symmetrical. This is not, right? There is something different. This is on the right side, to see that right and tuck 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 tuck, right? All of them, they are supplying. Good one. Left side, things are different. There are two. So this is smaller one. So we say this as hemiazygos vein, right? Like half cutting chai, right? Hemiazygos adi, right? Now this is extra, right? Well, it is not extra, but still, because the hemi word has been taken away, so now we call this accessory hemiazygos vein. But finally, to all of them, they are meeting into azygos, right? To see it, let's rotate. So now we are watching only the right side. This is only the right side, right? So we have rotated it, and this is the right azygos vein, right? Right side azygos. That's what we are watching. And all of them, they are nothing but they are giving to what's called as the posterior intercostal veins. Posterior intercostal veins. Great, right? So we talked about those arteries. So those arteries, they were coming from descending aorta, correct? And this azygos vein, that is giving this intercostal veins. And this one, you're right, this is the left side, right? This is the left side. Just from the structure itself, we can make it out, right? That this is the hemiazygos and the accessory azygos. You know this, right? And again, it is giving two branches too in the form of posterior intercostal veins, right? Don't forget that this one is accessory and this one is hemi, right? Azygos vein. Now we talk about important nerves, right? Sometimes these nerves, they are, when we start reading the nerves, they become so confusing, that phrenic and vagus and what exactly they do, right? Let's make it crystal clear, very simple. Phrenic, right, in thorax, things are pretty easy, right? Pretty easy. Because every function is very clearly defined as such in the entire body. Where was bronchus? Uh, Here we removed everything in this. Everything was removed because all the structures, we literally scraped off all the mediastinal structures so that we can just see these properly. Right? So every structure was removed. No bronchus, nothing. Lungs removed, bronchus removed, all major vessels removed, heart removed, so that we can see the posterior one. Okay. Coming back to this phrenic nerve. So phrenic nerve, it is, take it like motor, it is motor as well as sensory, to whom phrenic means diaphragm. So do remember that it is for diaphragm, right? It is for diaphragm. How many phrenics? There would be left phrenic and the right phrenic, right and left. Why? Because there are two domes of diaphragm, right? So that's how they will be supplying. To see this, their course would be quite similar, right? Except there would be some differences, so which we'll watch. We'll take the support of the structures which we have already seen. So we know about this internal jugular vein very well now, right? Such a big, so prominent, right? Just can't miss it. Very next to it, that's the phrenic nerve, this one. That's the phrenic nerve. So even in the dissection, even in the real dissection, you just watch, right? Internal jugular, something which you can never miss, right? Especially in cadaver, so they really look like this, absolutely black. Even in real cases, right? Real patients, when the surgery is done, so they will be very prominent structure, crystal clear, dark structure. And immediately you will watch lateral to it, the phrenic nerve. To understand that just under the bed, in the bed of phrenic nerve is the anterior scalene muscle. Anterior scalene muscle. Here it is. That is the anterior scalene muscle. It's hard to identify? Should not be. Right? Maybe, say, if you feel like that it is bit blurred, wait, it should be very easy. See? See, when you'll do the dissection, you should be able to identify just by touching that whether this is artery, whether this is vein, or whether this is nerve. When it is artery, right, and when you'll roll, so you'll feel that it is quite tough, but it is a hollow structure, right? It is a hollow structure, but you'll be able to feel that. In veins, they are very thin walled, right? Very easily collapsible. Their colors would be different. And nerves, so it has got its own identity, right? Its looks are very very crystal clear white, and you'll be able to identify it much easily. So won't be a problem. But when you know that this particular structure, this one, it is the anterior scalene muscles, so you can never forget, right? Because they are seen absolutely like brownish. These are the real images, right? These are the real images. So they exactly look like this. Confusion is only when we can't identify the structures properly. Then the trouble comes. But always take support of the structures which are very easy. So we see that this is anterior scalene. So which muscle could be this, where I am putting a dot, or let me put a star? Which muscle could be this? Which muscle could be this? The muscle on which I put the star. Which muscle could it be? Yes, that's right. It is middle scalene, and middle scalene and anterior scalene, they land on next 2-3 minutes. Let's put, yeah, middle scalene. So this middle scalene and anterior scalene, right? They start from cervical vertebra, right? From the anterior and posterior, they land on first rib because their function would be correct. Their function would be to raise the chest, right? Which muscle would be connected to the second rib to raise the chest? Correct. Anterior first rib and the posterior tubercle. End of the first rib. That's right. Very right. Very good. And we can see that this particular structure, right? This particular structure. Now I'm putting another star. Which structure is this? Which structure is this? Something which is going like this. This one. This one. Which structure is this? This tubular structure. What it is? That's right. It is right subclavian artery, because right subclavian artery is going behind the anterior scalene, and immediately we find that this one would be the right subclavian vein, which is passing in front of anterior scalene. Theek? Right? Very good. Very good. So this one is right subclavian artery. Achha. So that's how it goes, right, on the opposite side. Let's take out let's take this this internal jugular vein, that is right side. Let's retract it, right? Because when you retract it, when you take it on, if we don't revise this lecture, then a lot of confusion may occur. Well, you revise it once or twice, right? And trust me, thorax would become the simplest of the region. Because then you will be getting actually the connection, that when you will be talking about the brain and the blood supply of the brain, immediately you will say हाँ ठीक है, it is the vertebral artery, वो वहाँ से निकले, and then there is internal carotid, that is from front. All you need to remember that through the carotid canal, and that forms the circle of Willis. So that portion is done. Then you need to talk about only the arteries which are supplying the face, right? You just do this thing 2-3 times, and you will find it completely easy. But it is necessary, very necessary. Acha. The second important one, right? This is internal jugular vein. Internal jugular vein is now retracted, right? So with a retractor, right, we are just pulling it on one side, and just underneath we watch one of the finest structure, very important. And this one is vagus. Vagus, right? Alright, you just say, after some time, I have to ask you, Siddhant, how can you remember so many things, right? Because once you see this, na, it will be cemented into your brain. And honestly, I had so many confusions when I used to study. So then I figured out a method that no, it cannot be crammed, right? It can never be crammed, but if you visualize, so then it is easy. So many times you just close your eyes and then you say, chalo, let's start from the heart and reach to the brain, right? And then it's like a journey. Just you imagine, yes, this is now it comes out, and here, from here, this carotid, right? Common carotid, external carotid ek chota, but bigger one, internal carotid. That internal carotid is going up, going through those canals, and that's how you remember, right? You'll be able to really visualize it. When you visualize, becomes very easy, right? And few concepts. Wonderful. Exactly, Sally. That's the thing. That's why we have to retract. Otherwise, we were unable to see it, right? We were unable to see it. And if I say that this one is what? Common carotid artery. This one is common carotid artery, obviously the right one. So when you say to someone that vagus actually goes between, or still if you want to impress someone, vagus, right? Behind the vagus, there is right common carotid artery, and in front, it is overlapped by right internal jugular vein, and people say, wah, 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 kya baat? Arre, what wah, wah, right? This is the thing where we had to retract that internal jugular vein, and niche, this is the vagus nerve, right? Vagus nerve we saw, and still underneath is that right common carotid artery. So the whole sandwich is, right, Yeah, sandwich. Right? So a whole sandwich is that common carotid artery, it is just in deep. Almost, it would always be like that. Arteries are always deep because arteries are under high pressure. So when they are under high pressure, they are kept underneath, right? Deep, right? Then the vein, then the nerves, and most superficial are these veins. Right? That's why veins, they can be seen more prominently on the body surface as compared to the arteries. Right? So when the blood is taken, so it is taken from the veins. Difficult to differentiate between nerves and arteries here. Veins are just of dark color. Well, should not be a problem, because when you really touch the arteries, right, the arteries, they are very tough. Nerves, they are pretty delicate, right? And apart from few of the nerves, otherwise the nerves, they are pretty thin, right? Pretty thin. Acha. So this is the understanding. One nerve, right? Its importance would be when you will be studying head and neck. So do remember it, right? This is the area, right? It is this area, right? You can say that, see, this is what, right? This is manubrium, right? This is manubrium, right? This one. So just above the manubrium, right? So this is the area of larynx, right? So that's the larynx. So there'll be behind it, there'll be larynx. So anything which is going for the larynx, will be calling a laryngeal nerve. ठीक? But over here, this nerve, it will go beneath, right? It is going up. So I always remember that how the god must be thinking that he can larynx ko we need to give some nerve supply, and he forgets, kare bhul gaye. So then this is a nerve which is recurrent laryngeal nerve, right? Which is forming, which is coming out at a distal end, and then it is coming back up, right? So that's why it is called as the recurrent laryngeal nerve, which is emerging from below and then going up, right? So that is right recurrent laryngeal nerve. Just keep in mind that this is the point from where it is emerging. This is recurrent laryngeal nerve. ठीक? Acha. It will be, this is only for the right side. For the left, it is slightly different. So we'll talk about it. To see it with still better clarity, so we remove again the anterior chest wall, right? We remove the anterior chest wall, full wall, we remove it. And when we remove it, this is what we see. This is what we see, right? See the phrenic going all the way straight, right? Phrenic nerve, that is going directly down, right? Let's trace it still down. See how nicely, right? It is going. So over here, right, we watch that as it goes down. This is superior vena cava, right? This is the superior vena cava. This one SVC, right? So it is going along the superior vena cava, right? And over here, right? This was the subclavian vein, or the right subclavian vein. So this is the only point which you remember. Phrenic nerve, it goes behind the right subclavian vein. So that's why we had to remove this subclavian vein. This is the subclavian vein cut end. So that we can watch this, that this is the phrenic nerve. Just to remind that this phrenic nerve is going for the diaphragm, right? And do remember this point, behind subclavian vein, right? All these small points is good to remember, because when you will be watching CT scan, when you will be watching some of the clinical condition, these points will play a great role, right? Your understanding will be like flash. ठीक? Let's go further. going straight, right? Straight away. Then the course of action is, it is on the lateral side, right? It is on the lateral side and it is going all the way to the diaphragm, right? Nice one, right? And it supplies, it is sensory and motor to the diaphragm. Huh. We are on the right side, right? We are on the right side. So this is where we have removed the lungs, right? And we are watching the mediastinum, right? We are watching the mediastinum. This is the posterior part and this one is the anterior part, right? Pretty clear. So if we remove the entire lung, so the course of phrenic nerve, that would be like this, right? That would be like this. So it will be going exactly like this. So that is course of phrenic nerve, right? Thymus is, yeah, it's removed. In this way, it's removed. Thymus is the topic which we'll be taking separately, right? So many of the structures, many of the lymph nodes, thoracic duct, all of them, they are removed. Just to give the clarity, because if we keep on adding those, becomes complex. Once these basic structures are clear, then it would be much easier to explain rest of the structures. So yes, thymus and everything has been removed, right? So this is course of phrenic nerve in anterior mediastinum, correct? Anterior mediastinum. So that was for the right phrenic nerve, right? This is for the right phrenic nerve. Now we see the left phrenic nerve. See, so easy, right? Simple. This is the left phrenic nerve, the easiest of all, right? From where it is passing? Well, it is passing above what? This is aorta, right? This one is aorta, or you can say arch of aorta, arch, right? Arch of aorta. Then over here, this is what? This is pulmonary trunk, right? This is pulmonary trunk. Then that arch of aorta, right? It will be this. This is on the left side, the biggest chamber. So it has to be left. It has to be left ventricle. Well, this nerve is passing above all of them, above arch of aorta, above pulmonary trunk, above left ventricle, and it goes straight away to the diaphragm, right? It goes straight away to the diaphragm. And this is the left dome of diaphragm. So lands there and it's done. Remember, it is sensory and motor. Where does phrenic nerve originate from? Well, that part we are not taking right now, because then we'll be discussing only the phrenic nerve for almost half an hour, right? So regarding the origin, etc., that we'll take separately when we'll be discussing the theory part, right? The theory part. But when we say that phrenic nerve, so as soon as we say phrenic nerve, that picture should come. Say, if you remember, Siddhant, I told you that we'll be going for the dissection first. First we see the dissection, first we feel the structures that here they are, right? And then we'll be going for the theory. Otherwise, truly speaking, it never makes any sense. Just talking about that, a PowerPoint, that this is the phrenic nerve, origin, insertion, it supplies this, it supplies that, never enters into the brain. At least I never understood that. Once you see it, then, and if there is aha factor, हाँ समझ आ गया बस, then it becomes very easy, right? So that's why, yes, many of the things, many of the smaller details, I am deliberately not touching it, because that becomes a theory, right? Acha, this is so beautifully seen, so that it's without even any explanation, I can ask you that which structure is this, right? Because first time it is giving such a good darshan, right? Which structure is this, right? Which structure is this? It can be only one, Exactly, it is trachea. And why I said such a nicely seen, because we can watch tracheal rings, tracheal cartilaginous rings, right? Those tracheal cartil these cartilaginous rings, they can be seen. Bus, right? So crisp clear. C rings, exactly. C rings or the cartilaginous rings. They are like semis. Acha. Now we move on to the left vagus, right? Left vagus. Where is this left vagus? To see this left vagus, we remove these brachiocephalic veins. We'll remove superior vena cava also, right? We'll remove all of them and then see how it really looks like. So we saw that trachea, right? Trachea is seen clearly. And sorry. Acha. Huh. So over here, sorry, this is for the right vagus, right? This is on the right side, because so eliminate that part. When what I said is that for the left vagus we remove superior vena cava. No, right? Forget. For right vagus we have to remove superior vena cava because it is on the right side. ठीक है ना? Right? So for right vagus, we remove superior vena cava. Now it is fine. And because we removed superior vena cava, so obviously the brachiocephalic veins, they are also removed, because brachiocephalic, they are forming the superior vena cava, and this is on the right side, so we removed the entire one, right? So we removed this, we removed this, we removed this. So now picture is clear, right? That is removed. This one is the right vagus, right? That one is the right vagus. This one is trachea, right? This one is trachea. Now this vagus, right? This vagus, it is going down. It is going down, and here it is the esophagus. Esophagus, right? That's the esophagus. What vagus will be doing? Well, vagus is the parasympathetic supply to GIT. It is the parasympathetic supply to GIT. So then what about sympathetic? Where for sympathetic, there is sympathetic ganglia, sympathetic chain, right? In which there would be all sympathetic ganglia. A chain is formed. So from chain, things will be going. Fine. So done. Sympathetic and parasympathetic solution. It's problem solved. So it is this vagus which will be giving parasympathetic supply. And here it is giving it to esophagus, right? So that's how it is giving to esophagus. So that's about the right vagus, right? That's about the right vagus, right? I remembered Vegas like that it is like Las Vegas, right? So खा पी के मजा करो. So that's how I remember initially. This one is the left vagus. This one is the left vagus. And what left vagus is doing, it is over the arch of aorta, and it is going on to the esophagus, and finally it will go into the diaphragm. So this left vagus, right? See, it will also go through the esophagus to the esophagus, and then all the way to the diaphragm. All the way to diaphragm. So here it is, right? It goes. The point to remember is that for this we are talking about left vagus, right? Left vagus. And in this, as left vagus goes down, right? This is a small branch it gives at a lower level. And this is nothing but left recurrent laryngeal nerve. Right? Importance of this? Well, if anything happens over it gives hoarseness to the voice, etc. Right? But that is all clinical, which we'll deal with at a later stage. But that's the nerve, right? That's the left recurrent laryngeal nerve over here, right? So this we keep it for practice. Achha. Now see, you remember that we talked about intercostal arteries, intercostal vein, and intercostal nerves, right? Vein, artery, nerve. We talked about vein and arteries. Now these are intercostal nerves. Intercostal nerves, right? See this, this, this. These are all intercostal nerve. So above there would be vein, artery, and then the nerve, right? All into those spaces. What these intercostal nerves will be doing? What would be their function? Well, their function is both sensory as well as motor. Well, these are, right? These are like vertebral bodies, right? These are vertebral bodies. So function of intercostal, when we say sensory, right? So it will be carrying sensations. Sensations from where? Obviously, it is into the chest wall. So sensations from chest wall. So for chest wall, it is sensory. And for motor, motor name itself is telling intercostal. So it will be motor to intercostal muscles. Right? Done. So these are intercostal nerves. So far, so good, right? So far, it is fine. But from where exactly have they come? Right? That's the million-dollar question, that from where exactly have they come? Spinal nerves, right? When the spinal nerves, they are formed, they divide into two parts, right? Anterior rami and the posterior rami, right? Posterior and the anterior rami. Rami means branch, right? Rami means branch. These are the direct continuation of anterior rami of thoracic spinal nerves. Done, right? So if I write it like they are direct continuation of anterior rami of thoracic spinal nerves. So over here, vein, artery now, and we have removed that, right? But as we said, you remember that part which when we talked about, say, let's find out some space. Draw it over here. It will take a minute. Posterior, anterior, right? So there is first, this is the dorsal root ganglion, right? Goes like this because that is sensory, right? So this is the dorsal root, good, right? And then there is the ventral one, which is motor. So this one is ventral root. In ventral root, things will go directly, right? And this is what is forming the spinal nerve. But this spinal nerve will also be carrying some of the systems for the sympathetic one, right? So this is what? This is sympathetic ganglion, right? And it would be putting the fibers into the spinal nerve. This spinal nerve, as it will go further, it will divide. It will divide into dorsal ramus and the ventral ramus, right? Ventral ramus. So that ventral ramus or the anterior ramus, that is nothing but this is what we are talking about. Right? This is what we are talking about, that when we say that now it is the direct continuation of anterior rami of thoracic spinal nerve. That is when from the thorax, right, from the thoracic region, when the spinal nerves they come out, they divide into dorsal and ventral. So it is this ventral or the anterior, right, dorsal or ventral or anterior rami of thoracic spinal nerves. That's what we are talking about, right? That's how it really comes up. So this is for the spinal nerves. Now, if you can appreciate, right, this is the last part. This is the last part. I'm highlighting it because this is such a delicate structure that even with a very good photography, at times we find it a bit difficult. But it is seen so nicely, right? Focus on this area which I have highlighted. So I'll keep it as it is because that's why I put one more image. Here it is. Now can you imagine or can you really appreciate? See, I'll draw and then I'll remove it. Right, this one, this one, this one, this one, this one, this one, this bulk-like structure, this one, right? And now I'll remove it. Can watch some you might describe that some sort of say river which is going right over here, here, right? Removing again. Appreciate it, right? This is great. This is sympathetic trunk, right? This is sympathetic trunk. In reality also, at times it is so difficult to watch, right? But this is what is called as the sympathetic trunk, and this sympathetic trunk is formed by sympathetic ganglia, right? So can we see ganglia? Yes, we can. This is the ganglia. See the bulging, right? Say ganglia looks like this, and it goes like this. This is sympathetic ganglia or ganglion, right? This one, that is sympathetic ganglion. And it is this sympathetic trunk all the way from T1 to S1, right? From thoracic 1 to S1, right? Almost initial part of sacrum it goes, right? So this is what really supplies the sympathetic part and the parasympathetic is by vagus. Achha, one more thing. So though it is bit difficult to see, but see if you can. Can you see? I'm drawing it, right? Let's see. Very small, right? Very small. These are going like this. Can you see something which is connecting? See, these are nerves, right? Let's say these are intercostal nerves. Intercostal nerve, right? So this is that intercostal nerve. Chalo, right? This is fine. This one, right? I'm changing the color, right? I'm changing the color. This one is our sympathetic trunk, right? So far, all good, right? If you can, right? You want red? Yes, we'll put red, right? Now I'm zooming it because this one concept. Can you see something which is connecting that intercostal nerve with the sympathetic ganglia? Can we see a structure which is over here and now I'm removing it? See, right? I highlight it like this, like this, Can you see this structure? And now when I unzoom it, you should be able to watch that it is present almost at every level, right? Over here, it is like this. Over here, it is forming over here, right? See here, so it is seen more clearly. See, kitna badhiya, ekdam fine, right? So nicely seen. That's our posterior, that is our intercostal nerve. This is our intercostal nerve, right? Which is, right? So I'm focusing right now. I'm telling you to watch for this portion, this portion, this portion. You know what it is, right? It is, see here also, here so it is seen more clearly. So good. See this, right? I'll not draw anything in this image, just markers, right? See this, right? I'm talking about this part, right? I'm talking about this part, right? I'm talking about this part, right? They are rami communicantes, right? They are rami communicantes. Now, what are they? Very easy. These are rami communicantes, right? That means the fibers, because see, spinal nerves, they will be carrying the fibers because there are no special nerves, right? So these spinal nerves, when they are going, so this is the sympathetic ganglia, and via this, because it is the root which is carrying all the sensations, right? So these sympathetic ganglia, when they connect, right? So this is what is called as the gray rami communicantes, and this one is white rami communicantes. Rami communicantes. Acha, chalo, let's do one very quick understanding and it will become much easier. See, for the white rami communicantes, right? In very simple words, what exactly it is. These are, you know, the sympathetic ganglion, right? You know the sympathetic ganglion, right? Now, in this sympathetic ganglion, there are few fibers which are before ganglion, few fibers which are after ganglion. These are preganglionic fibers. These are preganglionic fibers. Right? Why are they white? They are white because they are myelinated. They are myelinated. So that's why they are white. Right? What exactly they do? They connect. Right? This is what we saw. Right? They connect anteriorly spinal nerve to the sympathetic trunk. Right? So connect spinal nerves to sympathetic trunk. Sympathetic trunk. Right? So general visceral efferent, general visceral afferent, right? All of them viscerals, right? They will be carried by them, right? General visceral efferent, general visceral afferent, right? Because things are going via sympathetic ganglia, they are not under our control. So this is white rami communicants. So this is this, right? So these are preganglionic. So now it becomes much easier that what exactly is this gray rami, right? Gray rami communicantes. Same way, it is just postganglionic, right? So these are postganglionic fibers and of sympathetic, right? So postganglionic sympathetic fibers. So this is, and why these are gray? Because they are relatively non-myelinated, right? So that's what we saw, that how they are connecting to them. So saving this file, and that's it for today, right? It was a pretty long session, but great. You all, congrats to everyone. So thank you so much. And tomorrow we'll be taking all these concepts with respect to radiology, right? So we'll understand first the principles of radiology, then we'll take the X-ray chest. First we'll see the normal X-ray chest, and then after that we'll start watching the variations, right? What are the things which can easily be understood. Biochemistry will take some time because say this thorax itself is going to take at least say few weeks, right? After that we'll be starting with other subjects. So depending upon how is the requirement and how is the interest of everyone, we'll work accordingly. Okay, so and I'm saving this file into our shared folder. Thank you so much and see you tomorrow. Bye bye.